Good afternoon, everyone. We'll begin with the next IC. Before starting the IC, Dr. Pallavi Joshi will deliver a keynote address on keratoscopy they have devised, uh, which is, yeah.
Fine. So, good afternoon, everybody. So, at the outset, I would like to thank AIOS for this opportunity to give the keynote address for this paper which we had presented in the last AIOC. So, our paper has won the best free paper award in the optics and refraction. So, this is a study we did about learning curve in the construct of a smartphone keratoscope prototype for keratoconus screening. So, as we all know, I have no financial interest here. Keratoconus is a progressive bilateral and ectatic condition of the cornea, and advanced stage usually present with apical scarring, acute eye drops, and eventually all these patients require to undergo some form of surgery. So keratoplasty becomes the only option. So early detection and treatment to arrest the progression and prevent vision loss is very essential at this era. We can't think about keratoplasty. So why this study? As you all are aware, the prevalence of keratoconus varies among different population, and it is estimated to occur 1 in 2,000 individual. And surprisingly, the frequency now the prevalence is more, and the Asian eyes it is 4 to 11 times more than what we see in the Western world. The reason being exposure to allergens as well as some amount of racial differences. And the investigation modalities which are available are the placidos based opticons, the pentacams, and the machines like oculizers. But all of these are solid organs, means basically we are using these kind of things which cannot be moved, they are very bulky. So the early diagnosis becomes inaccessible to large section of population, especially the middle and lower income. So we cannot take these devices to people who really need it. So with this in the mind, the aim of this study was, we had a collaborated study with Microsoft software professionals, and an attempt was made to create a simple device using a smartphone based keratoscope prototype. So this was basically a research prototype, was in comparison to the keratron based topographer. So we developed a machine and we validated this model. So that was what the study was. So here we analyzed what was the steep learning curve and applied this modification with respect to how the device evolved. And second was the smart KC app. There's one app which was there. How did we modify it? Last but not the least, we also saw how this device can be having good sensitivity, good specificity, and repeatability as much as the other devices which are used for keratoconus screening. So the construct struggle. So first, the struggle was to create this machine. So we named it as Smart KC because we wanted to put it with a smartphone. So it was named as a Smart KC. We had to choose the Placido's design. So there were different varieties which were available, and like the ellipsoid ones which you see in the extreme left, this is too wide to be placed on the eye, whereas the conical one is very difficult to fix. So eventually we went ahead with a cylindrical type with a central ring that was created, which had rings extending from 4 millimeters, which was closest to the eye, to 15 millimeters, which is to the other end. Then we created it, but we had issues like the working distance gap, that is between the smartphone and the eye, and the gap between the cylinder and the eye. So these two gaps created issues of pictures which are not correlating the one with the keratron. So the Microsoft people, thanks to the collaboration, they used a simulation system which produced the regression formula, and that corrected these gap errors. So eventually we need not create every time a new model. Because of this simulation, we were able to see which was the best way to correct this gap. So once we corrected this, we used actually a simulating 7.8 minimum radius of sphere, which acted like a cornea. Then the second issues we had was about the tilts and offset. If the fitting was not very straight, then the closer it went to the eye, we used to get a overcorrection, and if it was away, then used to get a flatter cornea. So due to this problem, we were wondering how to tackle this. So we corrected this in the app by adding a central plus mark. So when we added the plus mark, only when the image was captured at the plus cross, it showed the correct capture, and we overcame the problems of these tilts and offset. So just to show you all how this machine works, can you please play this? Yeah. So this is the simple phone, and this is LEDs, which cost hardly around 200 rupees, which is attached to a smartphone. Any smartphone you can attach this. This is a butter paper phone which is created of around 200 rupees. Overall construct of this smartphone itself is only up to 2,000 to 3,000. That's all, and it can be attached to any smartphone. So this is how the construct is of the smartphone. So what you see inside here is the light that is coming out, and we know this is going to create a reflection of the phone. So how does this work basically? Once this is a very simple way. We just click on, and here we enter the patient's age or ID. And once that is added, we go and capture the image. So first we go to the right end, and then this is the plus mark I was talking about, which will give the proper alignment of the placidos on the cornea. So once we know that it is exactly sitting in the center point, only then the image is captured. Otherwise it does not capture, it gives us error. So now it is given here, it is in focus and sharp, and that capture happens. So once we get that, we go to the other end. So apart from this phone, the app has correction for the exposure, sharpness, and offset. So it takes into consideration how the image is captured. Once it is captured, this placido's image is then converted into a cropped image view of the cornea. Then we go to the grayscale, and then it is an image mix. After this, we apply the basics of the subtraction, and then we apply the Zernicke formula and fit it over and get the heat map. So this is how the heat maps are generated. So with this, we got this. After this, the last and most important aspect of smartphone was whether it works as similar to any other screening device. So we used pictures from the Smart KC as well as from the Keratron, whose prototype we had simulated, and we compared it by sending it to two blinded researchers, the doctors. They didn't know which image was this, and told them to detect whether it was keratoconus, non-keratoconus, or was it anything else. And when we did that, initially there was inter-eye variability which was observed, because the SIMK values initially was captured for the 5 millimeter zone. Once that was corrected to the 3 millimeter zone, then the specificity and sensitivity greatly improved. So just to show you all, what you see on the right hand side is the Keratron output, whereas the other side is a Smart KC, and you can see that they are actually nearly similar. So we were able to get the comparable images. So the result of our study showed that the Smart KC had a sensitivity of 94.1% and specificity of 100%. And as compared to Keratron, whose actually sensitivity was good but specificity was less. Though we had issues with SIMK being variable, but the inter differences were not so much. So prior to this work, many people have conducted this, but they have never been such large-scale validation as we have done compared to the previous studies. So the limitation, however, is when this is just a research prototype what we had created, and we have to do this in a large scale. Second thing was, our data is only to a simple device. Now, if I say that, okay, I'll give it to you, you should be able to apply it to your device also. So we have to work on that. Third thing is, this app is collected by people who were trained. So if I have to give it to somebody without the training also, it should be user-friendly. So these are the limitations of this, but the study highlights that we have a Smart KC which is good, sensitive, and specific. So specificity indicates screening, and we are looking forward to modify this into a different type where we can use the AI and deep learning, so that these images which have been taken, they can be captured and a data is created, and we come with its own algorithm where we can pick up the keratoconic disease. This is a modified prototype which has now been created. We have done in the last 1 year, where we have slimmered the cylinder so that it fits easily and there is no problem with the patient. There's one more video, so can you just click on the video? There was a problem of fixation which now has been corrected here by putting two lights. You can see one right light which is for the
This is for the
right side when
fixation,
patient is
so
looking
that
from
the
the right
patient
type
is
of
always
fixation,
seen
and
into
the
the
left one was for
center.
the left fixation. As we all know, when we take a topography from reflection based, if this fixation is not there, then we can get picture without the centration. The principal axis can get altered. So this is being corrected. So this is how it is. And now today, after this 1 year of our journey with it, presently now this whole thing has been made an open source, and from the prototype of research it has now become a product prototype already, and worldwide interest has been created for this already. People like Remedio, Glaucos and Scott have actually come forward, and if you all are interested, there is a Remedio thing which has been put across here. Go into the trade and look, this prototype is actually available. You can look into it, see, and find out how it is when you hold it in your hand. So we are hoping that whatever we created as a research prototype gets into in next 3 to 5 years as an available low cost screening device for anybody to use to screen keratoconus. So with this, I would like to end my talk. Thank you.
The whole machine has come into the market, or still in the prototype?
Sir, actually, what we did was basically it's a research prototype. So when I meant open source,
You said in the
that is
Remedio
Remedio people have taken this because it's an open source.
Okay.
They have taken the device idea, they've used the app, and they have modified according to them. So they have now coming out in a large scale, and they are actually working on. They are also collecting data. I think they have collected. So it is going to come out as a product, sir. But it is not from Shankara. It is from them.
Okay. Thank you. Thank you, Dr.
Thank you, sir. Thank you so much.
Now I'd request our Chief Instructor, Dr. Mallikarjun, to deliver his talk on the management of corneal perforations with tissue adhesives.
Yeah, Dr. Bekar. No, I have another.
तो ये भी वर्क करता है वैसे.
Good afternoon. I am going to talk on management of corneal perforations with tissue adhesives. Tissue adhesives can be classified into non-biological, that is cyanoacrylate glues, and biological fibrin glue. These are the two cyanoacrylate glues. Those are available in India and market. The trade name is amacrylate, and it contains amyl 2 cyanoacrylate. This is a one we easily available in market, and it's quite cheap also. It is, I think it costs around 350 rupees. And fibrin glue, we all know it's Tissel made by Baxter, and even Reliance company also making this fibrin glue, but this cost wise is little bit more. And how does this fibrin glue works? cyanoacrylate glue works. First, it will go through the exothermic reaction, then causes a polymerization of liquid monomers and forms a solid polymer in a three-dimensional way. That's how it seals the perforation. And what are the indications for tissue adhesives used in ophthalmology? Corneal perforations less than 2 mm, and severe corneal thinning caused by microbial keratitis or desmatoseals, perforations caused by trauma and post-surgical wounds, also you can use it. And in severe chemical burns, if there is a severe corneal thinning, also you can use them. And in severe neurotrophic keratitis with thinning and other rheumatological condition which affect the cornea, also we can use tissue adhesives. There are few methods which you can use to apply the cyanoacrylate glue. One is the direct application. So you have to dry the surface of the perforation and directly apply 1 drop of cyanoacrylate glue and place a BCL. This is a video. It comes in a vial, and take the cyanoacrylate glue in a 1 mm syringe. And also you should not wait for longer because it will get polymerized in the syringe itself. So you have to dry the perforation with the Merocell sponge. And directly apply 1 drop of this cyanoacrylate glue on the perforation and place a BCL. That would seal the perforation. But problem with this direct method is the glue might go inside the cornea and it can cause endothelial damage, and also it can cause a toxicity to lens and cataract formation. So to avoid that, we can do a disc method, wherein we apply a small bit of cyanoacrylate glue on a sterile patch of around 2 mm, and that patch is applied over the perforation, and the BCL is placed over that. So this is how the disc method is done. This is the cyanoacrylate glue which we use in our institute, and it comes with 1 mm syringe and a needle. The glue is taken into the 1 mm syringe, and it should be done, the procedure can be done in OPD, or also it can be done in OT. The sterile drape is, the small piece of sterile drape is cut, and it should be little bit bigger than the perforation. If the perforation is 2 mm, you cut it around 3 mm diameter of the patch, and dry the surface of the perforation. And I put 1 drop of cyanoacrylate glue on the sterile patch, and that is placed over the perforation. So over that you can put a BCL. So how does it help means, it usually it maintains the counter of the cornea, and there won't be any bump of the glue when it polymerizes, and there won't be any irritation to the patients, and comfort level is better. But still, there is a chances of this still there is chances of glow seeping into the antechamber. So this is a one more technique actually described by Dr. Dua. It is called double drip technique. See, if you consider this is the perforation, a small disc is made, sterile disc, which is 2 millimeter bigger than the perforation, and that is placed over the perforation. And surrounding that perforation, the glue is applied. And one more disc is made that should be little bit bigger than the first one. And the underneath surface, the glue is applied, and over that the first disc, the second disc is applied. So in that way, it will make sure that the glue will not seep into the antechamber, and there will not be any toxic effects of the glue. As I said, the disc method has a more advantages over the direct application. There will be less incidence of foreign body sensation, irritation, and glue will take up better, and BCL would be stable. And what are the advantages of the double disc method or disc method? There will be a lower incidence of penetration of glue into the antechamber. And same way we can use the fibrin glue. The application method is same. Instead of cyanoacrylate glue, you use a fibrin glue. What are the complications? It can cause a toxic effect on the corneal endothelium and cataract. There can be giant papillary conjunctivitis. If you accidentally put it in the fornix, it can form symblepharon. And even if it goes more amount into the antechamber, there can be iridocorneal and iridolenticular adhesions, and also there can be increase in the intraocular pressure. So if you compare cyanoacrylate with the fibrin glue, the efficacy is same in the both cyanoacrylate and fibrin glue. The cyanoacrylate is non-biodegradable, less inflammation, it induces inflammation more, and corneal vascularization and foreign bodies reaction and tissue necrosis. The fibrin glue is completely biodegradable and induces minimal inflammation and less foreign bodies reaction and does not cause tissue necrosis. Cyanoacrylate glue is easy to apply, cumbersome to apply. Fibrin glue is easy to apply. Post-operative discomfort is more with cyanoacrylate glue and less with the fibrin glue. And cyanoacrylate glue has some bacteriostatic effect, and fibrin glue doesn't have bacteriostatic effect. And degradation of cyanoacrylate glue is slower, and fibrin glue is faster. And what will happen when you apply the glue means? Cyanoacrylate glue polymerizes quickly, and it gives a good tensile strength, and dislodges usually after epithelialization. It may take 1 month, and you can continue the drugs whatever depending on the cause of infective keratitis. Fibrin glue proliferation of fibroblast and formation of granulation tissue occurs within hours of polymerization. The clot organization is complete 2 weeks after application. The resultant fibrin clot degrades physiologically. Thank you. Next speaker is Dr. Anand, who will speak on intrastomal injection for infective keratitis.
Good afternoon, everyone. At the outset, I'd like to thank Dr. Malik and the AIOs for giving me an opportunity today. The topic that I'm going to speak about is intrastromal injections. As we all know, infectious keratitis is a major global problem, and scarring of the cornea is the secondary most common cause of preventable blindness in Asia. And it's very important that we have a prompt diagnosis and targeted antibiotic treatment, which is crucial for actually managing this condition. Now, the need, actually, when we talk about intrastromal, it's mostly the antifungal that we're going to talk about. And the difficulty is that the antifungal that are currently available in the market actually only treat the superficial infections. But what happens to the deeper infections? The problem is the antifungal drugs as such do not penetrate the deeper layers of the cornea. There is a limited spectrum, and there is a limited clinical response, and there is a prolonged course of treatment. And also the fact that these molecules are slightly large, and so there is a reduced bioavailability that is there. So that is where the intrastromal injections have come, which has become a game changer as far as the treatment for medical management of fungal keratitis goes, and it is mainly a targeted treatment. So here, the intrastromal actually increases the bioavailability, it increases the efficacy and reduces side effects, and also there's a faster recovery as compared to the topical medication. So like I said, there is a direct delivery. It overcomes the problem of poor penetration because it's directly at the site of the infection. It acts as a depot, and there is a slow release of the medicine, and there is a less epithelial toxicity. Now, when do we actually do it? So basically, it is indicated when there's a deep stromal abscess, which is more than 50%, or which is more than 5 millimeter in diameter, the presence of an endoplaque, or any recalcitrant fungal keratitis which has been non-responding for more than 10 days, and also patients not willing for any surgical intervention, or who are awaiting keratoplasty. Now, the most commonly used intrastromal medication is the amphotericin B and the vozole. The concentrations are what is written here, and the amphotericin B belongs to the polyene family where it binds to the ergosterol. It's more effective against Candida and the penicillium and the aspergillus, and this is how it is reconstituted before we put it onto the eye. The voriconazole belongs to the triazole group, which inhibits again the ergosterol. It is more effective against the Candida aspergillus and the fusarium, and this is how it is reconstituted. Now, nitamycin, which is not used, but still it's in the experimental stage, where you can use it, which is available in a lyophilized powder, and it has to be compounded in the pharmacy department. And nowadays, they also started using the water-soluble natasol, which is not commercially available, but the AIMS group has been using it, and they've been having good results with these particular intrastromals. Now, coming to the surgical technique, it is mostly done only under topical anesthesia, very rarely under peripheral anesthesia if the patient is very uncooperative. Generally, it is preferred to use a wire speculum because it gives more good exposure. The conjunctival sac is cleaned with 5% povidone iodine. The reconstituted solution is then loaded onto a tuberculin syringe with a 30-gauge needle. Now, coming to the surgical video. Now, what is important is the bevel has to be up and it has to be oblique. And it's very important that we inject the medicine from the normal cornea towards the area where the infection is. And it is done like a barrage around the infiltrate. And the stromal whitening that you see actually indicates how much the medicine has gone into the eye. And and it's also important that once we inject the medicine, it's important that we slightly withdraw the needle to prevent any backtracking of the medicine. So it is injected all around the infiltrate in the form of a barrage. Now, these are just a few clinical examples showing the pre and the post intrastromal, where it is cleared very well, followed by scarring. And this also is a smear positive fungal keratitis for which we had given intrastromal and which has healed well, and so is this. Now, coming to the various studies that are available, one of the landmark studies as far as the treatment of fungal keratitis is the TST protocol, which is currently followed by all of us in our day-to-day practice, wherein they have clearly mentioned that initially when the fungal keratitis presents, we start off with topical natamycin, and then we continue and look for the progression. If it is still progressing, then we add voriconazole. But even in spite of 10 days, if still there is no improvement in the symptoms or the fungal keratitis, that is when they advocate the use of intrastromal or the intracameral antifungal injection. Normally what they say is you can repeat up to 3 to 4 times with 72 hours apart. So if there is no response in spite of giving the intrastromal injection after 48 to 72 hours, you can still go ahead with the re-injection. Now, this is also another study where they have shown the use of the natamycin for fungal keratitis, but it's not, like I said, it's not commercially available, but the authors have found very good results with this particular intrastromal medicine. Now, this was a head-to-head comparison of all the 3 types, the intrastromal voriconazole, the amphotericin B, and the natamycin, where they randomized into 3 groups, and they found that actually all 3 of them actually fared well. But the patients who received the natamate actually healed slightly faster. But the patients who received the amphotericin B, though they had the same efficacy, it also, along with that, there was a lot of vascularization also. And this is also another busy slide showing the various studies with the outcome of the intrastromal injections. Now, the complication, they can be perforation during the injection, and sometimes if not done properly, they can be actually worsening of the infection or added on infections. And if the preparation is not properly prepared, compounded, it can lead to secondary infection, and there can be crystalline deposits and neovascularization with certain drugs. Now, intrastromal, the antibiotics can also be used, but though the studies are very few, there have been very few isolated reports where they have actually seen the use of intrastromal antibiotics. One among them being when they have used intrastromal antibiotics secondary to ICK, secondary to the streptococcal infection, and also the use of vancomycin, gentamicin, repeated tunnel infection. It is very important to also note that the gatifloxin and ciproflox should not be used as intrastromal because it can lead to macroscopic crystalline deposits. So to conclude, it is fair to say that this intrastromal is a safe and useful adjunct in the successful treatment of infectious fungal keratitis, mainly the deep-seated infections. The research is still required in this particular area, and we're still far away from getting the ideal intrastromal, which can give the ideal effect for what we are actually trying to achieve. Thank you.
Thank you, Dr. Anand. Before we have the next speaker, I just have a question for you. So you mentioned about using voriconazole as an intrastromal. What are your thoughts on also combining it with intracameral injections? Okay.
So normally I only give the intrastromal, very rarely I add it on to intracameral. Only if there's an endoplaque or something, then probably.
And also about the last slide on the antibacterial agent. So there are also some reports on amikacin being used for nocardia keratitis. So I think those have very good response in comparison with the other conventional broad spectrum antibiotics. Next we invite Dr.
Rupashri. Next speaker is Dr. Rupashri. She would talk on tips for air injection in DM detachments. In a nutshell, she will talk on management of DM detachments following cataract surgeries.
Good afternoon, everyone. Good afternoon, everyone. At the outset, I would like to thank Dr. Malik sir for giving me this opportunity in this AIOC. Dr. Sudhakar sir could not make to the conference, so I got this opportunity to present the same topic. My topic of presentation is tips for air injection in cases of DM detachments. No financial disclosures. As we all know, DMD is a common complication following cataract surgery and even all other intraocular surgeries, including glaucoma and VR surgeries. The reported incidence of literature is 2.6% for ECCE, but it is very less in phaco as 0.5%. The characteristic sign in DMD cases are severe, persistent corneal edema. On table, this complication can be sometimes noted as something floating in the anterior chamber, and most of the cases do not require treatment, but visual morbidity can ensue if large DMDs are left untreated or inappropriately treated. This can be diagnosed with the slit lamp examination in high magnification in oblique illumination. The detached DM can be seen in the slit lamp as shown here. When there is a severe corneal edema, ASOCT becomes a useful tool to diagnose this condition. This gives us the diagnosis of DMD, and also it helps us to select the appropriate treatment and monitor the treatment outcomes. There is a recent article by Dua et al., as I have mentioned here, regarding the types of DMD and the prognosis regarding the various modalities of treatment. I will not go into details of it. Coming to the causes of DM detachments, mostly it happens with the beginners because they will not know the proper instruments, how to assess the instrument, the sharpness of the instrument, and how to enter the anterior chamber. All this matters. It's more common in SICS and ECCE cases. It's also commonly noted in cases of inadequate anesthesia and akinesia, wherein the patient will be having squeezing of the lids, giving positive pressure, and also there will be eyeball movements which will be difficult to handle on table. Blunt instruments cause DMD, and beginners will not be able to assess whether the instrument is blunt or sharp, and they will try to use the same instrument in 2-3 times, and this can cause DMD. Anterior corneal entry can cause DMD. Irregular and large sections, shallow anterior chambers are also risk factors. In irregular and large sections, what happens when the instrument enters the anterior chamber or the irrigation enters the anterior chamber, the DM get detached. During nucleus delivery, especially it is seen in cases of hard cataracts and irrigation aspiration procedure, and also in cases of section hydration, wherein they go very much anterior to the section to hydrate it, it can cause. And it is seen with dense arcus senalis and also posterior crocodile chagrins, wherein the view will be hazy. There are multiple modalities of management, and conservative and surgical management are described, and all this depends on the height, length, extent of DMD and the involvement of the visual axis. In cases of large DMDs involving the visual axis, the first line of surgery is desmetopexy by air injection, and this may require repeated air injections until the reattachment is achieved and the cornea gets cleared. So desmetopexy is a surgical reattachment of DM. It is the gold standard treatment for DMD. Air and isoexpansal gases like C3F8 and SF6 are used. And I will describe only regarding the air injection. As in the other procedures, preoperative assessment is very important to predict the risk factors intraoperatively and to plan our management, how to face it when the risk happens. The deep socket, narrow palpebral fissure and anxious patients, better to plan peripulvar anesthesia rather than topical anesthesia. And peripulvar anesthesia is preferred because the extent and localization of DMD, if it is larger, then better to have peripulvar anesthesia. And to plan for the entry wound, I'll come into the next slide how to plan the wound. AC depth and irregularity has to be noted because most of the cases of DMDs will be after the consequence of complicated cataract surgeries or any other intraocular surgery. So what happens, most of the cases will have vitreous in the anterior chamber and floppy iris, so the AC depth may be irregular. Pupil size and shape has to be noted. If the pupil is irregular, then it shows maybe vitreous is present in the anterior chamber. Iris defects and synechiae are to be noted because if they are there, we have to release it because we need a regular depth anterior chamber to have a good air tamponade. Presence of vitreous in the AC requires anterior vitrectomy. Aphakia, pseudophakia and stability of IOL is very important again to obtain and maintain the air tamponade, because in cases of aphakia, the air will enter the posterior chamber and the adequate tamponade will not be there. In pseudophakia with unstable IOLs also this can happen, so better we should fixate the IOL or plan the secondary IOL, and accordingly we should go ahead with the air injection. Integrity of PC is very important because when it is weak and when we give air tamponade, it may give away. Surgical planning always, as I told, do the proper slit lamp examination and the anterior segment OCT when accessible, and map the areas of detachment. So we know now where it is detached and where it is attached. The portal of entry should be done in the area of attachment because in the areas of detachment it worsens it. Venting incision can be planned in the areas of maximum suppression. Here in this picture, as I have shown, there is only a small area of the clear cornea wherein the DM is attached, so better to plan the incision at that site. Anesthesia, as I told, lid squeezing may cause air escape, so all this have to be taken care of. And peribulbar block is preferred because sometimes in complicated cases we may need to re-enter the AC again and again, and the duration of surgery may be more, so it takes longer time. Coming to the proper air injection, it can be done with air cannula or 26 gauge or 30 gauge needle with the bevel down. And paracentesis, as I told, it should be done in the area of attached DM, and it should be perpendicular to the area of detachment, because it should not inadvertently enter between the DM and the stroma. It should reach beneath the plane of the DMD, and it may need, sometimes some cases may need multiple ports. If there is a DM scroll, some amount of saline should be carefully injected to unfurl it. And the visualization will be, first of all, very hazy because of the corneal edema and the haziness. This should be done very carefully. Avoid direct manipulation of the DM to reduce the, it will reduce the endothelial cell count, and inject air slowly. It should expand in the anterior chamber. This is the picture showing the DMD at the tunnel site. So the area where it is attached inferiorly, it will be a preferable site for paracentesis. As it is shown here in the AIOC picture, it is scroll DM that has to be unfurled. I'll show a video wherein this procedure is. Slide. It's there in the slide. No, it's not seen. In the preview room, it was seen. No, this system is not supporting it. Then how to do? Okay, the system is not supporting the video. This was playing in the preview room. I'm really sorry for it. Okay. After I had actually 3 videos which were again given by Dr. Sudhakar sir, showing the small area of DMD and a larger DMD and a case of DMD with aphakia. It was beautiful. I'm really sorry. After injecting the air, withdraw the needle very slowly. This is very important because the air should not escape from the anterior chamber. Maybe we can put a suture at the wound, keep it ready, and then slowly withdraw, and then tighten the suture. Eyes with poor visualization may need endo-illuminator, which helps in determining the orientation of DM. And supine position has to be maintained for 15 to 20 minutes. And slowly and partial release and controlled release of air should be done finally to maintain 2/3 of the anterior chamber with the air. Surgical PI may be needed to prevent the pupillary block and re-evaluate the patient after 30 minutes. This is very important, and alarm the patients for the signs of raised intraocular pressure like headache and vomiting to report early. Vent incisions should be done in cases wherein the DM is like a hammock, detached, and it is sitting in the anterior chamber, maybe touching the iris sometimes. In those cases, vent incision will egress the fluid. And when the vent incision is done, only the fluid should egress. That notes that your entry is in the correct place. If it is full thickness, then the aqueous also will, air also will escape, which is there in the anterior chamber. I'll show some photographs wherein the pre-op picture shows the corneal edema and which is cleared after the air injection. Again the same. At another case, near total detachment, which is very much clear, having very much clear cornea in the post-operative period. So the post-operative care is routine topical antibiotics and steroids, and in residual edema, hypertonic saline drops and ointments will help to speed up the resolution. It's not, again, without complications as like other procedures. Pupillary block and raised IOP are very common, and possible complications are CRAO, endothelial cell damage, DM loss, and redetachment of DM, and iris ischemia and Duretz-Zavalia syndrome have also been reported. Good prognosis cases are single DM detachments And superior DMDs, because when we inject the air will try to go into the superior quadrant, it will stay back. Hammock type of DMDs, early presentations. And guarded prognosis are seen in cases of torn DMDs, multiple DMDs, wherein the tamponade may not be completely attaching all the pieces, and inferior DMDs, and long-standing DMDs, wherein the fibrotic changes have happened, and loss of DM and fixed folds in the DM and interface OVDs are poor prognosis cases. So to conclude, DMD can occur anytime intraoperatively, and although spontaneous reattachment has been reported, factors favoring it are not clearly known. Desmetopexy with air injection is a simple, safe, and efficient procedure. It should be a preferred approach for DMDs and avoids delay in visual rehabilitation. Thank you so much.
Dr. Rupasri, if you have DM detachment on the table, so when you will decide whether to do the air injection at the same time or wait for some time, and what are the
First post-op day you have noted.
On the table you notice?
On the day one, when the patient is still with us, on the day one, when we have noted if the anterior segment OCT shows a shallow detachment which is not involving the visual axis, better to go with the conservative management. And if it is a large DMD involving the visual axis, better to go ahead with the air injection, because the delay will not give us any extra benefits. So the attachment will be
Any conditions where you wait for some time and do a air injection?
If it is not involving the visual axis, shallow DMD, small DMD, definitely we can wait.
Okay. Thank you, Doctor.
Thank you, sir.
How do you manage immediate post-op aphakic DMD, large DMD? You have met with a complication on table. You have not put a lens, but next day you find there is a large DMD. How do you manage this?
Yeah, in these cases, better to assess the corneal condition with the ASOCT, and if can be noted in the slit lamp, wherein map the areas of the detachment. One thing. Second thing, it's already aphakia, so see for the posterior segment if there is any vitreous hemorrhage, or why the aphakia has happened, whether it's any drop or segments in the vitreous which needs early intervention. In those cases, better to wait for a week's time with the topical antibiotics and steroids, since once the edema settles down, because the view also will be hazy and vitreous also will be still tending to prolapse in the anterior chamber, which hinders the procedure again. And then go ahead after 1 week or so, again repeating the investigations, if vitreous is there, do anterior vitrectomy, plan secondary IOL with air injection, because again multiple procedures cannot be planned later. With PI, sir.
Suppose you cannot plan an IOL immediately. If there is a pupil is open, and if you inject whatever amount of air or anything, it will go back. So how do you replace it? Do you trace it and suture it, or how do you lift that?
No, if the air bubble is in the posterior chamber in the vitreous, if the vitreous is very much liquefied, or you have done already anterior vitrectomy, it tends to come out, sir, into the anterior chamber. In those cases, you can, if the corneal condition is not allowing you to go plan the further procedure, you close the incision. Better the better vitreous settle down, give steroids for 1 week, 5 days or 1 week, then plan the secondary IOL.
So you mean to say if the DM is scrolled inside, how will you manage?
Scrolled, or it is almost total maximum.
Yeah.
You can't wait for a very long time.
So in those cases, you should not wait for longer time, because it might go for a stiffness or something like fibrosis. Then the unfolding would become very difficult. So if on the table you have a DM detachment, if it is scrolled down, and if you don't have any vitreous or cortex in the AC, or you have completed the surgery and put IOL, same time you can unscroll it with air. With air you can unscroll it from the other side, one thing, and make a air fill total. Or you can unscroll it and put a full thickness suture to it. So that is one thing. And these cases, if there is a big one and there is no, you feel that there is some amount of cortex is there, vitreous is there, viscoelastic is there, it is better to wait for some time, because all these things can come in the between the DM and the stroma. So it may not attach at the first instance. So the next speaker is Dr. Kavya. She would talk on corneal scraping technique and setting up a OPD lab. Because most of these infective keratitis, they first go to the general ophthalmologist, and who don't have their lab or thinking. So in those scenarios, how effectively we can manage, that is the um, ultimate aim of this presentation.
Thank you, sir. At the outset, I would like to thank Dr. Malik, sir, for this opportunity. It's a great privilege to be presenting alongside my teachers and the platform from which I started my cornea journey. I now work at the LV Prasad Eye Institute, Hyderabad. So I'd like to start off with a brief introduction of how my presentation is going to go. Start off with a need for corneal scraping, when to scrape, how to scrape, the challenges in corneal scraping, basic staining methods and microbiological appearance, and setting up a lab. So like Dr. Malik already mentioned, microbial keratitis and its sequelae form a major burden of preventable blindness in the developing world. So the need for understanding the necessity for corneal scraping, when to scrape, and instituting appropriate management can help and go a long way in preventing these disastrous sequelae. So these are some images that we all come across daily in our OPD. So if you see, everything looks very similar. So you have a whitish infiltrate, you have a reddish congested conjunctiva, the patient is coming to you with pain. So it's very difficult to differentiate clinically as to which is the possible causative organism. So what generally happens is when a patient goes to a person who is not trained in basic corneal diagnostics, they end up instituting broad spectrum antibiotics, and usually a combination of cocktail therapy of antifungals, antibiotics, antivirals, everything. And we don't know what happens, whether the ulcer is responding to it or not. And eventually when the patient comes to a tertiary referral after a couple of weeks, it is usually the clinical picture drastically changes because of the use of multiple medications, and then it becomes difficult. So trying to tackle it at a grassroots level itself and understanding what is a causative organism can go a long way in treating these patients. So like I already mentioned, the need for scraping, they all present to us at variable time points. So you don't know whether it's an acute or a chronic condition. They have undergone varied therapeutic interventions prior to your presentation. Sometimes they can present late with complications. There is an essential need to start targeted therapy. Scraping additionally helps to decrease the microbial load and allows better drug penetration as well. So this is a paper that was, it's quite landmark by Wilhelmus group, where they say that the positive predictive value of clinical diagnosis is only 65% in something as common as bacterial keratitis, and in fungal keratitis it goes down as low as 45%. So this obviously institutes the necessity for performing diagnostics as well. When to scrape a patient, ideally in all cases at the first presentation, irrespective of the history prior to therapeutic interventions. There are some ulcers which may not be amenable to scraping, like small ulcers with intact overlying epithelium, a healing ulcer with a small infiltrate, or a very large perforation which will necessitate therapeutic PK. A repeat scraping may need to be done also in some situations when you have not isolated any organisms on the first evaluation and there is no response to your treatment. If the patient's clinical picture is status quo or worsening, and you are suspecting a secondary or a mixed infection. So this is a basic tray of what you would need when you start about scraping a patient. The basic requirements include some very simple things: a topical anesthetic of proparacaine, what all of us always have, surgical blade number 15, sterilized glass slides, a marking pen because you'll be taking multiple samples, and some culture media for plating. So these are the common culture media that should be kept, although they cannot be stored in a hospital setting. In a collaboration with a microbiologist or a lab close by, they are very easily available because they are also used for other systemic infections. So blood agar, chocolate agar, Sabro's dextrose agar, BHI, which is a common liquid media, non-nutrient agar, and thioglycotate broth. A blood agar is most commonly used. It helps in isolating most fastidious organism and can also grow fungi at room temperature. A chocolate agar is made by heat denaturation of blood, and it provides some additional factors like factor 10, 5, and used for organisms which are more difficult to grow in blood agar like Haemophilus neisseria and Moraxella. So the process of inoculation is very simple. You have to use a C-streak method of inoculation and rub it gently over the surface of the agar. A fresh material should be used for each row of the C. And why this C shape is because it helps to differentiate between the valid growth and contamination. If you look at this image over here, if you see the colonies that are grown alongside the C shape, these will help you isolate the organism versus the other colonies that are here, which are most probably contaminants. The next agar, which may not be commonly available but is useful for identifying fungus, is the SDA because it contains additional factors. And lastly, non-nutrient agar, which is specific if you're suspecting Acanthamoeba keratitis. In non-nutrient agar, the C-streak method is not required. This is very important to remember. You can just use a single streak at the center of the plate. And liquid media, although not easily available, but some commonly used ones are the brain heart infusion broth, thioglycolate broth, and the Robertson cooked meat broth. So this is a picture of our fellow who is in a secondary center in Madanapalli in Andhra Pradesh. So this is a center which is very rural. It is not surrounded by any nearby tertiary centers and has the most basic of basic facilities. So because at LV Prasad we have a vast network of such secondary centers, but this does not inhibit in providing adequate care to the patients. So corneal scraping and microbiology examination is done at all of these centers. So I put this picture up specifically to show that location, geography, and resources should not be a limiting factor to treat these patients with utmost precision. So the first and most important step is instilling paracaine drops and ensuring that the patient is comfortably seated at the slit lamp to help you get the good sample. So this is a video that we have put together to show how the corneal scraping is done. So if you notice here, you have to scrape from the base and from the edges of the ulcer because will give you the maximum yield of the microorganisms. The stain for the gram stain should be evenly spread across, whereas the KOH can be put in multiple inoculates. And after you have taken the slide examination, the culture plates should be streaked with the C as I described earlier. So the blood agar is done first, followed by the chocolate agar. We also have access to the non-nutrient agar, but it is okay if it is not there as well. So this is a general procedure of how a corneal scraping is done. So to summarize, you would need 2 samples for 2 stains, that is the gram stain and the KOH, and culture plates based on the availability, but the basic would at least be a blood agar, chocolate agar, and any of the 2 agar for fungal cultures, which is PDA or SDA, and 1 liquid media if available. So once we have taken the sample, I'll move on to how you would go about setting up the lab. So this again is the picture of the microscope that is there at the Madanapalli secondary center. I have specifically put up these things that are not at our tertiary center but are at our rural centers. So there's no financial interest, but this particular model is about 30,000 rupees only, and there are several models which are available in the range of 30 to 50,000. But an additional point that should be kept in mind when purchasing your microscope is make sure there's an immersion oil objective as well, because you need that to evaluate your gram stain slides. So the common reagents that we need, usually 3 sets, the gram stain, which is most commonly used, the KOH, which comes in the form of pellets, as you can see here, and I will also be describing the trypan blue method of staining. Trypan blue, we know we use it in our cataract surgeries day in and day out, and we can easily use it to identify certain organisms as well. So this is a picture of the normal gram stain kit that we get. This costs about 13 to 14,000 rupees. It has grams crystal violet, grams iodine, a decolorizer agent, and finally the safranin or the diluted carbol first. So how do you go about doing the gram stain? I'll just play the video alongside. So once you prepare the thin smear, and fixation is not always needed, even air drying is sufficient. You flood the material with crystal violet for about 1 minute, and after the 1 minute is completed, you rinse it under regular tap water. The smear is flooded again with grams iodine solution for 1 minute, and the process is again repeated. You rinse it off again, and then you use the decolorizer with acetone alcohol solution, which is the third bottle that was present in the kit. And once the decolorizer is put, it should be immediately rinsed off. You don't have a waiting period over here. And once this is done, you do the final step of using the safranin or the diluted carbol fustin for about 30 seconds. This after all the four stains are completed, you rinse and observe under oil immersion objective. So this is how a normal gram stain is done for any corneal sample. So these are the two most common images that you will see in a gram staining. You have a gram positive or a gram negative. A gram positive, easy to understand, it retains the gentian violet and appears bluish in color. The upper image is a gram positive cockeye, and the gram negative, it loses the gentian violet in the decolorization and hence is pink in color. Can I take some more time? This is an image of the this is a video of the next step after gram staining is doing a KOH mount. KOH is also very easy again. You just need 1 drop of 10% KOH. You add a cover slip and then you view it under 40x magnification. KOH comes in the form of pellets. So 5 pellets of KOH is 1 gram. So for 10 ml, you would need about 5 pellets, and you can mix it with glycerol and distilled water of 8 to 9 ml. So this is extremely simple to perform. You just have to place it and cover it with a cover slip. And these are how fungal filaments, acanthamoeba cysts, and even microsporidia can be isolated under KOH mount. So this study showed that the sensitivity and specificity for KOH is as high as 94%. I'll just skip the calcofluor white slides in the interest of time. Okay. So lastly, I would like to touch upon the trypan blue staining. So we have looked at the application of trypan blue stain for easy diagnosis of fungal keratitis and also compared it with the regular gold standard of the KOH mount. So how do we do the trypan blue staining? You just take 5 ml of trypan blue. You can use this even with leftover trypan blue from your cataract OT, and take a 2 ml syringe into a sterile eyedropper bottle, add 0.5 ml of glycerol, and place 1 drop of this on a smear, mount it with a cover slip, and examine it under whatever magnification of the microscope lens you need using a normal halogen bulb white light. You don't need any additional objective for this. So this is very simple and easy to perform. And this is an image from the paper which shows image A is the calcofluor white stained sample of the same patient, and image B is the trypan blue. So you can see how a very simple cost-effective measure can easily help to highlight fungal filaments. You don't need anything very expensive. KOH has that difficulty of sometimes identifying the fungal filaments. Trypan blue overcomes it by beautifully delineating and coloring the margins of the filaments as well. Acid fast staining again is used when you're suspecting some atypical organisms. I'll just quickly skip this. So all things said and done, there will always be some challenges in performing these these scrapings. There may be insufficient material, small ulcers, non-separative keratitis, very advanced keratitis with keratolysis desmetocele, and deep stromal keratitis. So in these patients with poor response to therapy, require referral to a corneal practitioner. So my final take-home message is corneal scraping and microbiological diagnosis is essential in targeted management for better outcomes, can be easily set up in a clinic for smear examination. Culture examination, however, will require collaboration with a microbiologist, extremely useful in resource-limiting settings, and initial investment is not very high and should not be a deterrent. Thank you for your patient listening, and I'm sorry for overshooting the time.
We just want to take a smear and send it to a lab nearby. Like there's a lab like maybe 200 meters from the hospital. We don't want to invest in a lab setup, so we just have glass, take a sterile glass slide, just apply take it from the base and the edge,
of
apply it on that to prevent contamination till it reaches. We can send it in a sterile container.
Yeah, so usually the labs will also send you the slides in an airtight container. Even a microbiology lab in a hospital, in a tertiary setup, will send it to you in the OPD in an airtight container. So if you are collecting it in aseptic precautions and transfer it back to that and send it, that's good enough. No, cover slip will be put after putting the reagent on it. Yeah, so if you put it, then again you have to remove it, and that can lead to loss of the sample. So just leave it as such, and you can send it in the same container that is sent to you back to the lab.
Thank you, Dr. Kavya. And next speaker is Dr. Pallavi Joshi. She will talk on quick assessment of staining methods and patterns in dry eyes.
Good evening, everybody. At the outset, thank you, Dr. Malik sir, for this opportunity. So I will be speaking the last talk of this IC about staining methods and patterns in dry eye disease. So as a general ophthalmologist, or for that matter, for any ophthalmologist, dry eye, first thing is it's a dry topic. And whether it is a symptom the patient is telling because he has a dry feeling, or is it a sign that I have to pick, or is it a disease? So as we all know, we have come a long way understanding dry eye, and the Dry Eye Dues 2, which was actually published in 2017 after the workshop, gave this definition of it being a multifactorial disease. And what was most important, it was told, is loss of homeostasis of the tear film. And in this, there are components which we should understand, that there is a tear film instability, hyperosmolality, and ocular surface inflammation. With this, also when we say, "Arey, sab kuch theek hai, Sherman's is fine, I see everything okay," patient still complaining. That's when this neurosensory abnormality, which is now considered one of the most important aspect of a dry eye, has come into role. But this was in 2017, but people went to review this definition, and there were, after the dues, 4 more studies, group workshops, and they came out with a different modification which was clinically having some sense. And in this, they came up with something, an extra, which I marked in red. It says, apart from all that, a persistently unstable and or deficient tear film. So here, with that, there is also deficient tear film with instability. Ocular surface, epithelopathy, inflammation, and other aspects being same. So how do we normally approach? We give minimal time for history, which is actually wrong. It has to be the maximum time for a dry eye. Second is clinical examination, for which we give moderate time, and then investigation takes maximum time. But today, about stains and patterns, I will be concentrating on only those aspects which require up-team time for us to pick up what type of dry eye the patient has. Measurement evaluations, tear volume, do we assess? Not many of us. In clinical practice, Sherman's or phenyl red. Tear meniscal height, to some extent. Tear osmolality, not everybody can afford for the machine. LIPCOF, this is lid parallel conjunctival fold, which is one of the most clinical important sign all of us overlook. I'm sure you would want to go back and look into this. This has a very, very high specificity when it is mixed with non-invasive T-butt to pick up a dry eye disease. But today I am concentrating on stain-based evaluation of T-butt, ocular staining, lacrimal gland functioning, and lid margin assessment. Before that, a little this about the stains. Fluorescent stain is a vital stain. When you say vital, it tends to enter the cell without causing any degeneration. And the most commonest is fluorescent. 2 aspects of it. It will never go in an intact cornea. It will stain only if there is loose tight junctions or there is some kind of damage. Second most important point for picking up for staining is it is readily viewed in cobalt blue and yellow filter. These 2 aspects are important when we are seeing for staining in a dry eye. Whereas lecimine and rose bengal, what is the difference? Rose bengal is actually a derivative of fluorescent only, but it has one property, that it is cytotoxic. And it will stain anything which doesn't have a tear film on it. So it is not very specific. So it is out of vogue because patients with dryness, it's like jale pe namak, it will cause more irritation. So lecimine, on the other side, it actually causes vital staining. Vital stain is different and vital staining. So it has affinity to go over dead and devitalized tissue, and that marks out without any kind of this over the patient's symptoms. Now, the most important as a practitioners, we should understand, it's not just this dye, but which dye you use, how you use, and when you use. So the first thing you should remember is we always use the fluorescent. First, that is for the T-bud. After that, wait for 2 minutes. Then look for the fluorescent staining. An immediate stain will never give you the actual staining on the cornea. This is one thing we should always remember. Then use the lecimine green and then the rose bengal. Second thing is, ideally you should use a hanging drop technique for fluorescent. Excess of fluorescent, if you are putting, there's something it causes called as a quenching phenomena. Too much of fluorescent after some time will actually hyperfluorescence itself. So you'll not be able to pick up the stain pattern. So a hanging drop is an ideal way to touch and just put it at the lower lid. This is the second point. And always remember the lecimine and rose bengal, especially when we are evaluating for dry eye, don't put it in the lower lid because there is no tear film. So put it on the top bulbar area so that it trickle downs by gravity, and then the staining is better. So this is the third trick. Fourth thing, remember, when we have to see fluorescent, we need to keep full illumination. But when you have to see lecimine, it has to be always a low illumination. In low illumination, you better pick up the stain pattern. So start with the slow illumination, slowly lift till you will be able to see the stain. Last but not least, remember that this is very important that we should not do it rapidly. Keep a gap between the stains. So having said this, now T-bud, as I said, T-bud has a sensitivity or specificity compared to Schirmer's also of nearly 72% and 61% respectively, especially in Sjogren's. What is most important is, but variability is there that even T-bud can be abnormal in non-dry eye patients. So there has been the same group of people, Japanese group, which I showed you the redefined definition. They have come with this new thing where T-bud pattern is also taken into consideration to tell us what type of dry eye the patient may be suffering. This is very important slide, please concentrate. So they have come up with different types of breakups. The first one which is there is the area breakup. Second one is the spot breakup. Whenever you see area breakups or spot breakups, these are classic of aqueous deficient severe dry eye. Whereas when you see when the lid is moving up or the fluorescent is moving up and then you see this linear breakups, they are usually associated with mild to moderate. It's not that they are all severe. And when you get this dot blots, they are basically poor wettable. Classic of the evaporative is the random dots. If you see random dots, which is on the extreme right, they are considered to be mainly seen in evaporative dry eye disease. Anything between these drops also can occur. So this is something very important. I just want you to see, this is the first video which is played. I hope it is visible. You can see slowly one small area breakup occurs in this. Is it visible? There was a small central area breakup that occurred. Whereas in this, you can see it is a random breakup in this patient's eye. So you have to give that time for the patient to blink 3 times before you ask him not to blink. So when you see that, suddenly you can see you are able to pick it up. So this is hardly 10 seconds and see the beautiful random spots which you are able to see. We need to see this properly and give it time. So similarly, the extreme, side, you can see there's a mucus debris. That is a severe dry eye. So you will actually see P's already. So there the T-bud is 0. So depending on the pattern of breakup, whether it is area, whether it is dot or dimple, you can make out what type of patient's dry eye is. So direct observation of lacrimal glands, this is another new thing which has already come up, and a very beautiful paper come out by Swati Singh and et al., where they're actually observing the lacrimal gland secretion. So see here, this is also a very simple clinical judgment you can do. You can differentiate between dry eye, evaporative and aqueous, and also the cicatrizing. Just observe. You can see the thing that's so beautiful. This is an active lacrimal gland secreting from their ductules. So you're able to see. So this is how you can pick out. Actually, what they do is you have to take the pictures, and then there is a formula for this where which it is converted to tear volume measurement. But for us, even seeing this as a simple, availability of a fine dispersion indicates that aqueous deficiency is not there. Whereas in this picture, if you see, I've waited for long, but absolutely the dye does not. This is in a patient with dry eye disease. Just to give you the comparison, I'm showing this. Okay, so 2 points with respect to the T-butt and the lacrimal stainings is what we covered. Now let us go to the ocular surface staining. Sir, can I take 2 minutes, sir? Yeah. So here, why do the ocular surface stain? We have to understand in dry eye patients, mild and moderate patients do not have the staining pattern. I'm sure you must have observed stain, but no, the stain is not taken. Usually the moderate and severe patients, when cell death has occurred or there is so much of inflammation, hyposmolarity, that there is loss of the mucin layer, the tear film glycolex has been damaged, only then you see the ocular surface staining. Okay. There are a lot of ocular surface staining score, right from National Eye Institute, Oxford staining, the Van Bridgesworth, which was rose Bengal based. But Sika ocular staining is one which I feel is a better one because it takes into consideration two things. One, fluorescent staining and your Lissman staining. So what this scoring shows is the central part, it is for the, you basically count those dots. So you have 3 points for the central cornea, that is for the conjunctival staining, and the peripheral, lateral and medial is for the Lissman staining. Depending on 0 to 30, more than 30 or confluent, it is given 1-1 score. Any central fluorescent staining is a +1. Any filament is a +1. Okay, so this, when you add together, total score of anything above 9 indicates that the person is having quite a severe dry eye disease. So this is available everywhere, you will get it, but you have to collaborate everything together and connect it. In ocular staining, one thing we have to understand, every standard score has central scoring, lateral scoring. What we have to understand is, always in a dry eye, the staining will be more on the nasal side because everything goes on that. If in a patient you see a lateral staining, especially in Sjogren's, that means it is very severe. This is something we should always remember. And last but not least is, it's not a one-time cross-sectional staining. It is periodic observation of your patient. A rheumatoid patient will come to us for at least 3 times in a year. So that periodic staining and periodic photo taking will help you see the differences. And that will give you how much of them are actually getting converted to a systemic association. You'll be surprised, actually the same Sika group, they have studied patients with moderate to severe, that is score of more than 9 to 12, are having row SSA or SSB positivity being very high. So when you see patients with stain positivity, make sure that the patient is sent to an immunologist also. Okay, so this is a few patterns of staining. Superior stains, we know, usually occurs whenever there is something like a conjunctiva callosis or SLK, whereas diffuse is classic of a dry eye, and inferior stainings are usually seen in meibomian gland diseases. Mucous debris also take up the stain, and this is just to show the Lissman stain. See, Lissman stain, see the illumination, it is very less. You can see that. So first is the grade 1, grade 2, grade 3, grade 4, where it is very confluent, whereas that is the rose Bengal staining, what you are seeing on the other side. So last but not least, in patients also, we should not forget to see the lid margin, especially those who are chronic contact lens wearers. Chronic contact lens wearers develop a lid margin epithelopathy, which becomes like a wiper effect. So in them also, we have to use Lissman stain it twice, put a stain, wait after 2 minutes, re-stain, and then evert the lid and assess the amount of lid involvement. So if they are having significant staining, you know that it is a contact lens associated problems, or this also we see in patients with cicatrizing diseases like the Steven-Johnson syndrome, where there is LMK, that is a lid margin keratinization. So stains are right from T-butt, for your lacrimal gland, for the corneal staining, and the lid. So this is the pattern and this of the corneal stains which we have to look into the dry eye disease. So to conclude, stains of ocular surface are essential armamentarium for dry eye disease, and we all have to do it. Give it time. It takes only 5 minutes. 20 seconds maximum for a T-butt, Sherman's ke liye 5 minutes, and staining 2 + 3. So it's not much, but it is a deserving thing for a severe or moderate to dry eye patient, and it will help us to pick the diseases faster. So I would encourage everybody to buy a few fluorescent Lissman in your practice, and make sure that you do it for patients who have this kind of complaints. Thank you.
Thank you, Dr. Pallavi. That was
Thank
a
you,
wonderful
sir.
presentation.
Thank you.
See, usually in general practice, what they do is they can do Sherman's test
Yes,
and
sir.
T-butt and fluorescent staining. So only managing with this, how to classify the dry eye and start the treatment. That would be the main difficulty for all the general ophthalmologists, because there are so many eye drops are available in the market,
Yes, sir.
and so many molecules. and which one to give in what conditions.
So that's why I told the importance is with the new classification of T-but pattern.
Okay.
If you are able to do, see, fluorescent only we are using, sir. So in that only just assess the T-but. If you see the pattern of breakup is like that, if you find that they are random spots, and you just do a lid margin expressible, because I have to cover only pattern, I have not covered the
I
mibography.
understand.
So just express the lid margin. If you find that the lid glands are blocked, you have P is inferior, you're finding T-but of a random type, you're finding that expressibility is showing block, then we are dealing with the evaporative. So in that, now I'm sure everybody knows, no financial interest or this, but Sustain Complete, which is come, is actually very good for patients with evaporative variant compared to the other variant. So they are now targeted drugs which are coming for aqueous, for evaporative. So like that they can. So 2 minutes of understanding the T-but, sir. I feel people do Shermers, they do staining,
Yeah,
but T-but, that 2 minutes is not given. So maybe we should make it as a practice to do the T-buts in all our patients. That is very essential, sir.
Just in short, where to choose HPMC, where to choose CMC, and where to choose carbomers.
Okay.
Any particular, like,
You're asking my personal choice or any? See, CMC is comparatively the most favorite of all, and whenever you have these additions, like additions of something which is available. So if you have computer vision syndromes, patients who have just so then I would prefer the CMC or HPMC. Both work fine with contact lens, whereas CMC is better. If there is inflammatory eye, I have seen that, like, just to mention, where there is glycerol, addition of other medicines, they don't do well. So inflammatory eye, simple CMC, HPMCs are good. When you go from moderate to severe, that's where I give the additional drugs. Apart from this simple CMC and HPMC, then you have the HP Gore, the combination of, like the Terra Lube and all those, where you have additional add things, then you go for that. When it is very severe, then yes, your sodium hyaluronate and those variants are taken. That's how I step ladder them.
For evaporative, even sodium hyaluronate is better. And to add more tears, when there is no tears, that is aqueous deficiency, you give CMC. That is a simple rule you can follow.
So CMC is the basic which is there. Yes.
Yeah.
Thank you, sir.
Thank you. Any more questions, please? I think I will conclude the IC. Thank you all for attending this IC.
It's
Yes,
very
sir.
nicely designed, especially for the general ophthalmologist. It enlightens in a lighter way. It's very beautiful, and really thank you for the nice.
Thank you, sir.